pressure monitoring. So the supplies that you're gonna need are going to be a 250 or a 500 cc bag of saline. You're going to need your barred intra-abdominal pressure monitoring kit. You're going to need a single transducer kit or setup. You're going to need a pole to put it on and a transducer holder, and a Foley, which you already have in the majority of your patients. And lastly, you'll just need a level because we will be leveling to the iliac crest instead of phlebistatic access. So before we start setting it up, I want to just talk about when you're obtaining these, what the patient should be doing or what they should look like. So the patient should be laying supine. We should obtain it on end expiration, just like if it was a CVP. They should be, our goal should be for it to be less than 15. Remember we talked about that we start to worry if it's over 15. And that's pretty much the gist of all of that. So now that we have all of our supplies, we're wondering, how do I know how to set this up? Well, it's really nice that the device has the instructions right on the package. Also, if you go into the ICU break room, the same set of instructions are behind the door in the break room in the ICU. So you can find those right there. So what do we do? If you are not a person who likes directions, I'm going to break this down and make it really simple for you and user-friendly. So we have our kit, we have our saline. We are going to take our single transducer kit and we're going to strip it down. So the only thing that we need out of here is just this part. So when we're done here, it's going to look like this. This is all we need. And why is that? If you're the person who needs to know the logic and the reasoning behind it, this already has your kit, your intra-abdominal pressure monitoring kit already has enough tubing. You don't need anything extra. So we just need the part that's going to give us our numbers, the transducer part. So we have our cord and the transducer, and that is it, okay? So, and the other thing that you need to know is you need to cap the end of it, and you're gonna put a cap on the end that has the cord, okay? Make sure it doesn't have a hole in the end because that will mess you up during the priming process, okay? All right, so we are going to take that. All this extra tubing you can literally just get rid of. And then when you take your intra-abdominal pressure monitoring kit out of the package, just wrap it all around this bowl. It has these beautiful labels that are so user-friendly. So 2 transducer, 2 sample port, and there is a third one that says 2 saline bag. So it is extremely user-friendly. I did not add these. They literally come out of the package like that. So when we start by spiking our saline bag, which would normally be a 250 or 500 bag. This is just for educational purposes. So we spike our bag. Notice that there is no pressure bag with this. That is different from the CVP or ART lines. You don't need it. So we spike our bag. That's step 1 after we collect our supplies. So step 2 is going to be connecting it to our transducer. So our stripped down transducer here, we go ahead and connect, okay? And yes, we do have that third label telling us where to go, but we are gonna hold off on that because we need to prime first, okay? Now I want you also to note that you have this other part here, okay? So this is where you're going to place your Foley, because on this, it tells you you can either be draining your urine on this side, or you can turn this and you can be collecting a sample, or you can be monitoring your intra-abdominal pressure monitoring. So you're going to flip this depending on what you want to do, okay? So all you have to do is make sure it's on drain when you're placing it in there, and place it close to where your sample port is on your Foley. So it just lays in there like so. While we are priming, we are just going to leave it to drain for now. So we're going to go to our syringe, and normally in this kit this would not have fluid in it. It's just for educational purposes that it already happens to have fluid in it. So it would come out of the package empty and would not be pulled back like it is. So if we can imagine that I'm pulling this back to draw fluid out of the bag, so it would be coming down here. And then I'm going to go to my transducer here. So everything is currently turned off and I need to open it up. So we look over here at our stopcock and we need to turn it. And this is one of my vented caps, if you can see. And I want to prime my tubing, so I'm going to push my syringe. Just get this over the trash can here. Push my syringe until I see that all the air is out of the entirety of the tubing. Okay? So if you need to pull back a second time, if you need to pull back a second time here to get all the air out, you can. So pulling back to get saline out of the bag, and then pushing it through to get all of the air out of the tubing. And there it looks like all of my air has left. Oh, there we go. So then once you do that, you turn your stopcock off, and of course I would switch this out with a cap that is not vented because I don't want any air getting in my system accidentally. And I would normally have a transducer holder here, so I would slip that in so it could be held there, and then I would connect to my monitor, okay? So at this point, now that all my tubing is properly primed, this would be the time that you would connect where it says to sample port. I would want to clean this with alcohol. Open this and put it on here. Okay, so I still have a sample port I can collect urine from if I need to, which is why over here it says sample. So we can turn this and either get a sample or do our monitoring. For our purposes, now we're going to talk about the monitoring. How do we do that? So now that we have primed it, we would level the transducer to our iliac crest. Have the patient supine, of course, before we did that. We would zero our monitor once we set up our waveform on the monitor. We would take our syringe, draw back 30 mLs into our syringe, and we're going to give it a nice steady push into the patient's bladder. It's very similar to when you're doing cardiac output. And then we're going to look up at our monitor. It's going to be very similar to a CVP waveform, and it's very similar to the numbers that you would see. So it's going to come up like in the 200s, 300s, something similar to that, and then gradually come down. So when it gradually comes down and is kind of staying consistent around a number, you're going to watch your patient for that end expiration, and on end expiration, that's the number that is your intra-abdominal pressure monitoring number, okay? And that's how we do it. So every 4 hours, if it starts trending up or getting to a point where you're getting concerned, and we talked about those numbers, then you start talking with your physician, or maybe considering doing it more frequently. If you guys have any questions, you can always come and talk to me and I can give you more information. Thanks, guys.